My name is Srihari Naidu. I'm here with Dr. Hima Vidula. We're the co-governors of the American College of Cardiology from New York State. And we have a wonderful night scheduled here for the next hour. We're going to hear from Dr. Valentin Fuster. And you see the title here, Subclinical Imagenomics 2020 to 2022, which is an interesting title. And I'm sure we'll hear a lot more about where he's going with this. This is the 20-year anniversary of when Dr. Fuster first came to give this lecture. He was the first person to give the New York Cardiac Center lecture. And 20 years later, we've invited him to come back, which gives us a really nice vantage point in history on where the field is going, which I think we'll all learn from. There's a couple of housekeeping issues. One is that there is CME for this event. So if you have registered, which I assume you all have by participating here, you will get an email after this event, and please fill that out. There is a time limit for that, so please make sure you get your CME on time. In addition, this lecture will go about 45 minutes, and we'll have about 10 to 15 minutes for question and answer. That'll be moderated by Dr. Vidula. Please put your questions in the chat or the Q&A, but preferentially in the chat so we can look at those, and we'll try to answer as many as possible through the discussion section. If there are any questions that we can't get to, then we will be sure to respond to you by email after the event. And this is being recorded, so this will be also present on the internet and on the website afterwards as well. So please monitor your chat and ask questions there. So without further ado, I'm going to introduce Dr. Fuster. He doesn't need an introduction, but he certainly warrants it and deserves an introduction. So I'm going to give him one, and I know he didn't want it too long, but we'll hit some of the highlights of his illustrious career. As most of you know, he's director of the Mount Sinai Heart and physician-in-chief of the Mount Sinai Hospital. He's held various really high-end leadership positions that any of us would be thrilled to even be anywhere at that level. He's been president of the American Heart Association, president of the World Heart Federation, member of the U.S. National Academy of Medicine. He's been chief of cardiology at Mass General. He spent time at Mayo Clinic. And then he came back to Mount Sinai, and he's been there almost 30 years now. 2 years from now will be 30 years, really leading a preeminent cardiovascular medicine program, as we all know. He's editor-in-chief of the journal Nature Reviews, and he's also editor-in-chief of the Journal American College of Cardiology, which we all know him well from, where he's put together really a stellar group of editors, as well as amazing publications. Obviously, he's a legendary academician and has done research in large areas, including atherothrombosis. He has an H-index is over 205. For those of you who know what that is, it has to do with citations and impact. And the list goes on and on. He really is the only cardiologist also to have had the highest awards from all four of the main societies: the American Heart Association, the American College of Cardiology, the European Society of Cardiology, and an International Society of Cardiology. These are all research and living legend type awards. So we are honored to have him here. I know I am very intrigued by this topic because we go through medicine and oftentimes we pick what's out there to do, but Dr. Fuster is always looking at the future, and pay close attention because you might figure out what you might want to do in the future. So without further ado, Dr. Fuster, take it away.
Well, thank you very much, Dr. Naidu, Dr. Vidula. It's a pleasure to be here. When I go back 20 years, of course, one thinks, well, how I'm going to approach a lecture 20 years later. And there are two approaches. One is to go historically what happened, but I thought was going to be much less boring to really move on and to perhaps make a prescription of what will happen in the next 10 years or so. So we have been working over the last 10 years, actually, in trying to understand health. And we work on disease for many years, but now we are very intrigued. What is health and what maintains people to be healthy? So, and this is an age-dependent program that we have, different ages, health is different. The title that is intriguing to you, Dr. Naidu, says Subclinical Imagenomics. What we are really talking about is the combination of imaging and genomics in people who actually do not have manifestations of clinical disease yet, but there is subclinical disease, which is identified by imaging, and then genomics is being done at the same time on a predictability basis. So let me move into what has happened at least in ourselves recently. We were working on the development of atherothrombotic disease. And unfortunately, we all worked very late when the disease was already very advanced. This first phase moved into phase number 2, which is the one we are having now, and that is how the disease develops. Can we maintain this artery completely clean? We are talking today about arterial disease. And if we do, what technology we need to understand what goes on? And this is actually what I have here, is the combination of new technologies, Imagenomics, which is the topic I'm going to be talking today, artificial intelligence, the understanding of the single cell that circulates in blood and can tell us a lot about us. For example, a monocyte can provide a lot of information on the genetics and many, many things. And then innovative therapies, that is, can we start doing trials in people who are much younger and certainly begin to understand how the disease develops, for example, at age 20, age 30. Well, let's move into the reality that I mentioned a minute ago. If we go before the disease takes place, we have here different ages, 60 to 100, 20 to 60 years, and from birth to 20 years. This is how I'm going to start. What is the challenge in people between age 20 and age 60? I think you will agree. The challenge in terms of arterial disease is, I am developing the disease. I don't know, but I would like to know. Well, let me tell you what we have learned about this particular question. Here we are. We are now dealing with what we consider a healthy individual. We are not sure, between age 20 to age 60, and we are going to address the issue of imagenomics. First of all, you know the risk factors for cardiovascular disease, and basically we talk about 7. It's 2 mechanical, which is obesity and high blood pressure, 2 chemical, cholesterol elevation and diabetes, and then 3 more behavioral, which is smoking, and an abnormal diet is not necessarily obesity, and lack of exercise. And what we all thought is that these risk factors affect the endothelium, and then with the endothelium is being affected, actually LDL cholesterol enters into the vessel wall. This is a little bit more complicated, as we will see in a moment. Well, we said, if we want to know the natural history of health, maybe we can look at technologies available today, but my friends, technologies, optical coherence tomography, we are doing in patients who have disease, and only 1 out of 1,000 people in the world might be able to get into such technology. So there's no way we can learn about the disease by using invasive technology that has an impact on a population, which is what I'm talking about. So we decided to develop new technology, which is ultrasound, 2D and 3D ultrasound. And actually, we began to utilize this technology in 4,000 people between age 40 and age 55. These are people, workers in a bank in Madrid, equal men and women. And we decided to develop this technology, which now has been very widely validated. And that is, you can say a cross section here, you see a plaque that is beginning, this is longitudinal section, and this is progression of the disease in about visit 2, which is 4 years later. We are following these people for 20 years with the technology I mentioned, plus CT for calcification of the coronary arteries, an indirect approach to the coronary arteries. Basically, we are dealing with 6 arterial regions, both carotids, the aorta, 2 iliofemoral regions, and the coronary arteries indirectly. What we learn, something very interesting, this disease begins in the iliofemoral region in about 75% of people. And that is, but the manifestations of the disease are first in the coronaries because are small arteries, and any obstruction may cause problems. But the reality in the iliofemoral region is very large, and nobody has claudication at age 40. That's basically an interesting aspect, the first thing that we learn. Well, then we look at these 4,000 people. In the left are male, in the right are females. And look what we found, very fascinating. Under age of 50, about 2/3 have already atherosclerotic disease by this imaging technology. This is one of the 6 systems, 2 or 3 of the systems, 4, 5, or 6, 2/3 of males and 50% of women. So we are dealing with what we learn at autopsy in young people. This is a disease that starts at a young age. And actually, we will see in a moment that in fact tends to progress actually relatively rapidly. We are following these people for every 4 years, as I mentioned, in 41% was already progression of disease in the second visit. So having said this, then we decided that near 1,000 of them, 900, we could do PET scanning of the arterial system to address where inflammation takes place. Here you have it. And then magnetic resonance imaging to address the fibrotic lesions. And this is what we are finding. The so-called fatty streak at autopsy actually tends to progress to a fibrotic lesion. And the process stops. Not totally, but this is the key situation that we found, and you will see this in a moment. When there is deposition of a foreign body, like cholesterol in the arteries, the bone marrow is cold, macrophages get into the foreign body, in this case is cholesterol, and there is a fight, there is a war there. And the question is, can the macrophages take out all the cholesterol that is deposited? And then the lesion is converted in a fibrotic lesion. I think this is what is happening. But what we will see later is that if the fat deposition really overwhelms the artery and there is not enough macrophages, these macrophages commit suicide. They feel they cannot take care of so much foreign body, in this case cholesterol. And this suicide is an apoptotic phenomenon. And these cells begin to release cytokines in a tissue factor, promoting clotting and plaque rupture at the end of the story of the natural history of arterial disease. I think this is a very important concept, this war that exists between something that is a defense mechanism and the substrate. COVID-19 is the same thing. COVID-19 is a foreign body, and the macrophages react, and the question is, who is the winner? And you know about the natural history of COVID-19. The foreign body is overwhelming, and the macrophages may give up at the very end, releasing cytokines and so forth, and the patients end up with a tremendous problem in the lungs and in the intensive care units. This is a process very important biologically, the war between a defense mechanism and a substrate that is a foreign body. And here you have the examples. Here you have the bone marrow lights up. You can see in blue. This is how we do with positron emission tomography. And then we go into the arteries, and there you have the inflammatory process. So we have done this study, and it's fascinating how the bone marrow reacts to a foreign body that is cholesterol, and an inflammation takes place in the artery. And we can see this in the study that we just did. Interesting. These are the risk factors that I mentioned, 7, isn't it? More risk factors are present, more is the number of lesions that we see in the inflammatory positron emission tomography. And this is fibrotic. And look this blue, what that means. This blue means the iliofemoral region. So what we are really trying to convey here is the risk factors that I mentioned have a huge impact, not only in the incidence of disease, but in the progression of disease. And this is what we are seeing in this natural history that is actually in vivo. By the way, the talk I gave 20 years ago was very much based on autopsy. Look how much the field has advanced. Well, the first concept then I can convey here is cardiovascular disease, atherothrombotic disease begins early, is silent. The iliofemoral region appears to be in a large proportion of patients where the disease begins, and risk factors and inflammation are the real drivers. So actually, we use the device now in the iliofemoral region, and if we see disease there, we can already predict the disease will spread all over the arterial system. Well, there is a question now. We see many patients who come with acute syndromes, coronary syndromes, and they don't have a high risk factor profile. And we look at fibrinogen, Lp(a), we do all of these. But there is something else that I'm going to present to you today, which is fascinating. These are all of our individuals, 4,000, and they are divided by Framingham in high risk, middle risk, and low risk. Well, this is actually what we talk about the risk factors, and just see a significant number of our people had just one risk factor or none. And look, 50% had already subclinical disease. And the question is, due to what? And this is the story. The story is that, for example, if we look at LDL, normally we talk about levels of 100 to 120 as being normal. But look, there is a lot of subclinical disease. The colors means red is more disease than actually this color here, light color. But basically what we see is what we consider normal, which comes from heart attacks, strokes, and then it came out, this is the normal levels, is absolutely wrong. To have no subclinical disease, you need an LDL cholesterol less than 70. But there is more. By correcting all risk factors and statistically doing the right things, we found the same in hemoglobin A1C. Hemoglobin A1C 5.5 to 6, you say pre-diabetic. It's not pre-diabetic. We already see this. So I think that this is an issue. We saw the same in triglycerides. So the first thing I'm telling you is what we consider normal today is all based on people with heart attacks, strokes, and so forth, but they didn't look earlier in life, when in fact is where the process begins. But there is something else. The cardiac study that started age 18 to 40 years was an observational study that has been going on for a large number of years now. They didn't have good imaging technology, but we certainly look at what happened with the burden of disease risk factors in the first 40 years of life. If you go to guidelines, we all talk, let's see the risk factor at age 40, and then we are going to predict. My friends, we are going to predict too late because the whole process begins here. And let me show you the data. And here we are. What was the cumulative effect of LDL cholesterol in the first 40 years of life in the cardiac study? More and less dictated the events. And this actually very, very important, because these events that we are talking about are real myocardial infarctions and actually mortality. And everything actually, the best predictor was what happened in the first 40 years of life. And this data we presented now, this in LDL, now we have in all the risk factors. We didn't pay attention. First, what we call normal is abnormal. Cardiovascular disease is frequent without obvious risk factors. Risk factor levels we consider normal is actually abnormal. The disease is developing. And risk factors age cumulative is not considered. What happens with the accumulation of risk factors in the first 40 years of life. So I agree that we see patients with high Lp(a), patients with high fibrinogen. I think the key, however, of these people that we think do not have risk factors is because what we consider normal is not, and the subclinical disease is developing. And in the first few years of life, what is happening, the cumulative effect of these risk factors, now we pay a price later in life. Having said this, we now develop the first study that is going to be a randomized study in young people, is the pre-CAT trial design, which we have people between age 20 to 40 years, we draw their blood, and then we look at the lipid profile. We consider abnormal if it is more than 70 milligrams DL. And then what happened, randomization between active treatment to lower the LDL less than 70, and then the control group, just guidelines. The guidelines in young people is correct risk factors. There's no much there, unfortunately. Completely forgotten what we consider is the key of the disease, young age. And here we have the follow-up, which is exactly what we have done up until now, to look at the burden of disease subclinically. However, many of you may say, you may progress in the control group, the disease, and not in the active group, but progression not necessarily means events. Well, because these are young people. Well, we'll see secondary endpoint are actually events, but these are very young people. We are going to follow for 10 years. Maybe they are not events, primary events. So how can we convince that progression lead to events when these people are too young and the primary endpoint is progression? And this is the data. We now have data in 6,000 people between age 60 and 100. And I will tell you, 12 years of follow-up, this data is fascinating. It's going to be published very soon. This is mortality. And you know what this is? The burden of disease 12 years before subclinical disease. So what we found is if you start a little bit late at age 40, for example, in this case, age 60, you can predict in a 12-year follow-up mortality by the burden of subclinical disease 12 years before. So what we are going to do in the PREDIMET study is when we see a burden of disease with progression, we say what this progression meant when we had these people at this age 60 to 100. And then we can begin to project the prediction of cardiovascular events in a study that will be done in young people. So, and this is the third concept. Cardiovascular disease, of course, appears in early life. Then you have a unique approach with a very strict levels of LDL cholesterol that we call abnormal. And this is higher than 70 milligrams DL. And this is the randomized study that we are now in preparation of the final phases for starting the study, but it's very, very exciting. Well, here comes the question. The clinician says, excuse me, you're talking about imaging, you're talking about progression, you're talking about trials, the disease starts early, but what I do with my patient that comes to see me today? That's the question. Well, in these 4,000 people and in many other groups, we have actually done 2 studies of therapy. One is individual and the other is group therapy. The individual therapy, basically, you go to an individual who has hypertension, for example. This is a group actually in Kenya. These are the investigators, but these are the number of individuals there because they cook with salt and they keep the food with salt. They have hypertension. Then you can go individually and have some interesting results in such individuals. But I will tell you one thing, the individual approach to risk factors is not easy, is expensive, but I have more to say in a moment. And then we have 3 studies that we finish of group therapy. And that is 10 people get together, you are obese, I smoke, I'm going to help you, you help me, and they meet twice every month, and they go on for a year or 2 with this kind of peer pressure, I would say. And then we look at this compared with controls. Well, I'm going to pull a number of studies together with just one example, because this has been absolutely the reality. This is the story. In this case, yeah, this was a group therapy study. Of the patients, of the group of patients, the 4,000 I presented to you. And here, what you do is you do a workshop, you teach everybody what the situation is in terms of risk factors, the group that is controlled, the group that you intervene. And then you have here fantastic results at 12 months by correcting risk factors. But look what happened afterwards. There is a drop. And the question is, why the control group does so well here? Because it's an environment, it's a culture. And this group knows that there is another group that is being intervened, and then everybody actually gains. But the problem is sustainability. And we have seen this in all the studies we have done. We as humans can really, whether it's group therapy or individual therapy, we can actually have a successful results for a year or 2, but then things fall apart. And then we have to reintervene. And that's our hypothesis today, that the reintervention is going to be with exponential benefit. And this is the concept that I want to think is critically important. And that is cardiovascular disease and risk factors. We can modify individually, expensive, as a group therapy, less expensive. The results may be very similar, but there's no question that this is not permanent, and we have to look at sustainability. This is very important to keep in mind, that we should not get in a way, how can I say, frustrated, because we go with a patient and then they come 2 years later again, obesity, smoking, and so forth. It's the reality. But our hypothesis today is the reintervention is going to be exponential benefit. And we have a number of studies starting on this. But we didn't talk about genetics. What do we have to say about genetics? What is most important? What I mentioned up until now, the risk factors, or genetics? Well, we joined forces with the ARIC group, the group in Sweden, Malmö. This is our study, the bioimage study. And this actually is the Boston Health study. And what was decided to do is to have a strategic risk approach on the risk factors I mentioned, more risk factors, unfavorable results as a hypothesis. But how do you do a risk stratification on genetics? And what we did, we pick up 50 genes that in the literature appear to be involved in coronary artery disease. And we picked up these genes, and a stratification was made by the number of mutations that were available in these individuals that we follow. And actually, certainly a good correlation between high risk, a number of mutations, with actually cardiovascular events. And the same with the risk factors. But the question is, which is most important? And here are the answers that I want to convey. First of all, both are independent, quite interesting, except in familial hypercholesterolemia. And in patients with diabetes type 1, very difficult to say there is a dependence between the genetic factors and the acquired factors. That's number one. Number two, most of the people have one or more risk factors. In fact, in the United States, 97% of people have one of the risk factors we mentioned, and only 2-3% do not. What means that these people at high risk, what we did is we gave these people, if the high risk was driven by LDL cholesterol, we gave statins. And actually, it was a significant decrease in the risk. So to have a genetics that are unfavorable, not necessarily means that we should not do anything. This would be a terrible mistake. In fact, you can correct the risk factors that are acquired and still have genetics. And you will tell me, well, my father had a heart attack at age 40, and my mother, and says, I have a very bad genetic profile. I will tell you, you may be wrong. Maybe both were smokers, and you are smoking too. So what we are finding in these genetic studies is the family history. You have to put many things into question, because the transmission may be of the acquired risk factors rather than genetics. We learn this with the studies like this. And now the third point is fascinating. The question of gene mutations. Let me explain what I'm talking about. Now it is becoming very clear, and we have done a number of studies on this. This is one of the first published, in which the bone marrow can actually send cells. It can send cells to the artery that are mutated. That is, the motor engine is failing there. You can send a defense mechanism to take care of the cholesterol, and doesn't function because the genes are mutated, those genes that are of defense mechanism. This clonal hematopoiesis of indeterminate potential is called CHIP. And I will tell you an example of one of the genes that are protective, is TET2. And let me tell you about the findings. Here we have a bone marrow ready to react when there is cholesterol in the artery. Well, the reaction can be so good that the monocytes that come out from the bone marrow produce a fibrotic process. We saw this at the beginning. In a place where, or a section of the artery that has fat may become fibrotic. Very fascinating. Here you have something that is interesting. You need cleaning here. You have a plaque that rupture, thrombus formation, and here the type of macrophages that come in, we call them macrophages type 1, here is type 2. now we are about 7 to 10 different macrophages, but this is how this field began to evolve. And here, what these macrophages do, they clean the artery. Here they is profibrotic. This cleaning can be very troublesome. Why is troublesome? Because maybe cleaning too much, and this may cause trouble in an artery that already had a problem before. Well, what is interesting is TT2 has a role, is to prevent this mechanism of cleaning to go too far. And if TT2 is deficient, is mutated, this can be devastating. So of all the factors or genes identified, TT2, when it is mutated, is very bad news. And actually, we have Kanashkisuvab in the studies that were done, in Boston, in terms of trying to avoid the inflammatory process. What is actually was done is to block interleukin-1 with Kanashkisuvab. Blocking interleukin-1, you prevent this process to go too far. It's like having a good TT2. And this is very interesting in therapies today. We are moving into therapies to enhance the defense mechanism that the body has. And this is a very good example. Well, having said this, here is the story now, that we have cholesterol in the artery. The cholesterol is overwhelming. The war is established. At the beginning, it seems there is not enough cholesterol, and the macrophages turn these plaques into fibrotic. But if there's too much cholesterol, we have the suicide that we mentioned before, and these macrophages committing suicide become apoptotic, and then they release the cytokines, tissue factor, that may be when the disease, vulnerable disease, leads to heart attacks. But there is a second possibility of these late events, CHIP, that is the macrophages that get into the system, into the foreign body, the engine is not working because one of the genes that is supposed to be defensive is mutated. So now the whole question of what is happening with the defense mechanisms, there are three aspects. One, it works when there is substrate of cholesterol, healing of the artery. Second, if there is too much substrate, the macrophages decide to quit, and they release all the cytokines leading to heart attacks and tissue factors. Or third, maybe the macrophages are fine as a defense mechanism, but there's CHIP, that is the immune system or the genes of the macrophages may be affected and defense mechanism fails. And now there's a lot of debate. It appears that these heart attacks in earlier stages of life have this mechanism, and this CHIP appears to be important in elderly ages. Very interesting. I said at the beginning, and I think you remember well, that in fact, the risk factors affecting the endothelium and making cholesterol to get into the vessel wall was a very interesting hypothesis, but was not so simple. Let me tell you what we are finding now. With these sophisticated technologies of positron emission tomography, for example, we find that the bone marrow spontaneously reacts in people with metabolic syndrome. This is reaction in red, bone marrow activation, in obesity, in hypertension, etc. So we are now beginning to see that the risk factors not only may affect the artery directly, but they actually may stimulate the bone marrow. And this is fascinating. So we have many questions now coming from the field of imaging and from the field of genetics. And this leads to this point, number 5, that is, we have cardiovascular disease events now. Maybe apoptotic macrophages, maybe gene mutation or CHIP, but there's something else. Bone marrow may react secondary to vessel wall foreign body, which we have been saying from the very beginning, but perhaps some of the risk factors may stimulate the bone marrow from the very beginning. So it's a very complex aspect. But this is the concepts, the 5 concepts that we have learned about people between age 20 and age 60. That is to learn who is developing the disease at the very early stage. And this imaging technology, I don't have any question, are going to come up in the next 5 years or so. and you will look at the iliofemoral region, we can begin to predict already. What is the actually challenge between age 60 and age 100? There's no question. The challenge is cognitive function. So let me tell you where we are. We are now here. And this is the story. We started the so-called transatlantic study, United States and Europe, in 2021. And we are now in the middle of this study, which is fascinating. And this is the hypothesis that the risk factors that actually affect the large arteries may also affect the microcirculation of the brain and lead to cognitive dysfunction and acceleration of Alzheimer's, the same risk factors. So we start with people, pathway 1, that have neurocognitive dysfunction, and then we use all the imaging technologies. Now in green is the large arteries, carotids, iliofemoral, ultrasound, and these are the risk factors. And in red, we go to the brain to look for amyloid with PET and to actually look at the amount of blood that circulates in the brain with MRI. So to look at the microvasculature. And here's the opposite. We start with the large arteries disease and we go to the brain, neurocognitive testing, and then also looking at by imaging, PET in the brain with amyloid, functional, an amount of flow in the brain, and then the risk factors in the large arteries that you see here. It's like a crossover study. Let me tell you the preliminary results that we obtained. First, the risk factors in cardiovascular disease, they lead to mortality, and I don't have to discuss this any longer. But what we have now, data indicating that the risk factors may lead to large vessel disease, but also microvascular disease in the brain, as we have assessed with actually quantitative volume of blood that circulates in the brain with MRI. Not only that, with positron emission tomography, we have seen that in these circumstances, with decreased flow, there is less glucose uptake in the brain. And not only that, we have cognitive dysfunction. But there is more. Dr. Cortez in the National Center of Cardiovascular Investigation in Madrid that we are working with is leading a fantastic project on Alzheimer's. In a mice model with Alzheimer's, this thrombotic phenomena in the small arteries. And the question is, maybe this predisposes to the acceleration of Alzheimer's. Well, let me tell you about Alzheimer's disease, and this is fascinating. Alzheimer's 100 years ago said, my disease is vascular disease. And we wonder if the same risk factors that affect the large arteries by the mechanisms I have been describing may affect the small arteries of the brain. And this is not causing Alzheimer's, but maybe accelerating Alzheimer's. And we know that beta amyloid, as is seen in the mice model, is prothrombotic. So here's the question. Maybe the risk factors that cause large vessel disease lead to cerebral hypoperfusion. They lead to altered brain metabolism. The uptake of glucose is decreasing, cognitive dysfunction, senile dementia with risk factors that have not been treated before. Or perhaps this is also happening in Alzheimer's that you have here. Or maybe in Alzheimer's, there is thrombotic phenomena that accelerates the disease. And we are now looking at the possibility of large trials with antithrombotic therapy in people with family history of Alzheimer's. This is actually the possibilities. However, nothing is perfect. What I presented to you are cross-sectional studies done not in the same people. Every study of the 5 was in different people, but then we unified the hypothesis. Now with Dr. Cortez and others, what we are looking at is longitudinally the same people with all the technologies I mentioned, and using also injury of the brain. You know, we have now like troponins of the heart. We can assess injury of the brain when these diseases begin to evolve, degenerative brain disease or Alzheimer's disease. So what I try to convey to you is the same risk factors that can cause heart attacks and strokes. We see patients that says, you know, you are bothering me. I will continue to smoke. My weight, forget about it. I will die suddenly anyway. When we tell these patients that the brain may be affected by the same risk factors and they lose cognitive function, they change drastically. So one of the messages that we are getting with these studies, practical messages, the greatest impact that we may have in a change in behavior in terms of risk factors is to talk to the patients about the brain, rather than talking so much about the heart. And this is something that we are learning. Now I am finishing. I have 10 minutes, and I want to tell you what is the key of the whole situation is young age. We have been talking all along about young age or healthy arteries. What happens between birth and age 20? This is what we are talking about here. Young kids, you know, at age 3 to 6 have a small number of centers in the brain. So they capture what we tell to these children. Adults, we don't capture so much. There are too many centers and too many crossovers. So that's one point. And we began to work with a television program, educational Sesame Street. And one of the first things that happened is Cookie Monster, rather than eating cookies 7 days a week, they ate 1 day a week. This had a huge impact in children. And this is how we started the studies, is to go into children, age 3 to 6, 5,000 children in Colombia, Spain, and in Harlem, New York, randomize half of them into an intervention of 60 hours of health over a period of 6 months, how the body works, healthy food habits, physical activity, and how to control the emotions. And this is already published. Fantastic results compared with the control group. Point number one. Point number two, here is the data. Very early, after the intervention, we have great results. This is very interesting, but we got a problem, and this is number three, sustainability. Don't look at the slide, it's too complex. But we are now working with 50,000 children that are randomized at different ages. The problem is what we achieve at this very young age, and we predict that whatever they learn at this age will come out as they are adults. This is the great concept, and everybody knows, look at yourself. Your behavior today has a lot to do with your environment at a very young age. It's a lot to do with it. With this hypothesis, we reached the conclusion that maybe we should reintervene these children. And here we have all the different reinterventions that we have in these 50,000 children, in which, in fact, we have the same that we found in adults. Sustainability is the problem. But our hypothesis is we have children at age 10 that were intervened before. We are going to reintervene. And we have children at age 10 that were not intervened before. We will see much better results in the group that were intervened previously. So we have a number of projects in adults and in children that have the concept that we are all human. And what we need is reintervention and sustainability. And our hypothesis is that reintervention will be of exponential benefit. Number four, now we are going to start in New York, in the 5 boroughs of New York, a similar project. Again, 2,500 children in this case. But here we are going to validate what makes a teacher a good teacher for this project. Is critical how the teachers interact with these children. Second issue we're going to look is at the pollution, extremely important. We are going to look also microbiome in these children and the inflammasome. What is the immunological reaction that these children have? Fantastic project to be done in New York with everything I presented today in children, which I'm summarizing. Again, 2 towns in Spain are going to be randomized. In one town here, Cardona, 5,000 people, another town, Cheyenne, 5,000 people, and all the projects I presented to you today are going to be done in these 2 towns. People at different ages with the different things I presented to you today, with the concept that we can change the health of a town by what we have learned through investigation, whether it's imaging, genetics, etc., and when to act and how to have sustainability. So that's basically the issue. And finally, we have learned something very interesting. And I mentioned this to you before. The the culture. Whenever we do all these studies, it's interesting, the people around the intervened groups at different ages, they do much better. So I think the culture is probably the main weapon that we have today. Children is important, the educational aspect, but the main weapon is probably what we are talking about is the culture. So why we don't get into the family? And this is what we have, the Family University of Health. Basically, the 4 items I presented to you, how the body works, promote physical activity, healthy food habits, and encourage better management of emotion. These are actually the 4 aspects that we teach during the 6 months and 60 hours. And this one is very fascinating. We actually teach children how to say no when in the future they are presented with drugs. These are the 4 aspects. So now we are going to get into the families. And you see, over a period of 1 year, each of these aspects has 2 weeks. And then it's repeated, but more sophisticated, and repeated and more sophisticated. And we are differentiating the grandparents, the parents, the children, the grandchildren. This is important, different ways to present the 4 boxes in the whole family. And now at the end, we'll give a diploma, which is a Family University of Health, signed by a Muppet, is Dr. Rooster. So basically, what we are thinking with all of these, we start with science, we start with imaging, we start with the brain in elderly age, but we are moving more and more into childhood. And now we are beginning to apply everything we are learning at a much earlier age. So this is the summary of what I presented to you today. Later we start, higher is the cost and less is the benefit. Earlier we start, higher is the benefit and less is the cost. And what I presented to you today are actually, if you realize, 15 different concepts. 5 concepts were in people between age 20 and age 60. 5 concepts which I didn't have the time to present to you, but at least I elaborated into the results that we are obtaining, relates to the brain. Between age 16 and age 100, this is the problem: cognitive function in Alzheimer's disease. And finally, the 5 concepts of projects in children that I think I just summarized. But overall, I wanted to give you a sense today of what I think the next decade is going to be. We are going to move more and more towards health, to identify individuals, and they will identify by subclinical disease. Genetics will be important. And in all of these, we will get in culturally into groups of people that can be in banks, they can be in different environments, that the people working there, their families may be involved in these studies. We can go into places where investigation is carried out. We are going to start the family study actually in the National Center of Cardiovascular Investigation in Madrid with investigators' families. So getting earlier and earlier into children, into the culture even much better. But most of all, we are doing science with the best technology available today. And this is why the title was Imagenomics, because imaging and genomics are essential into most of the scientific aspects that we are learning, that then we are transferring into what this can have an impact in the population as a broad concept. Thank you very much for your attention.
So Katerina, we'll now move to the Q&A.
Yes, we have a couple of questions in the chat.
And are you able to enable the video?
Which video?
Okay, I think we're set. Thank you, Dr. Fuster, for a very inspiring talk. Very thought-provoking. You know, I especially found it inspiring how you took research from the bench side and clinical research and are applying it to children and families. That's truly, you know, very inspiring. We have a couple of questions from the audience. One question from Dr. Montagnino is, what is the incidence of atherosclerotic heart disease in patients who have died from cancer?
I don't know the incidence. I will tell you, by age, the incidence is higher than in patients that don't die of cancer. However, if you look at the older population together, it's not higher because patients with cancer die earlier. So there is an issue here. And the issue is that the same risk factors or some of the risk factors that cause atherothrombotic disease can actually produce cancer. So there is a sense that both actually implement each other. And this is basically can be done by looking at the incidence at the same age, in which, you know, in a way, you can see that the incidence of cancer, the incidence of subclinical disease, for example, is actually very significant. It's like one pushes the other. However, when you look at later age in general, without discriminating specifically a given age, then cancer people die earlier. So it's a completely different situation. But the question is a very interesting question. Obesity may contribute to cancer. Smoking can contribute to the cancer, and many other aspects actually. I don't want to get into the diet now, but there are lots of studies that actually one promotes the other.
Thank you, Dr. Fuster. Dr. Montagnino had a separate question. Please comment on the dietary generation of TMAO and its role in vascular disease. What do we know about the microbiome and vascular disease?
Nothing. Let me tell you, it's very nice to talk. Everybody talks about microbiome. Then you go into the data, and the data is very controversial. And obviously it's controversial. We are dealing with millions of bacteria there, and we are dealing with lots of products in the diet that are actually altered by such bacteria. If we have problems already to say which is the right diet, when we eat a banana or eat whatever it is, you can imagine how the different diets may be altered differently in different individuals. Therefore, it's hard to give an answer at this time. And people who try to give answers, I have great questions, because the bio actually probably intervenes into the risk factor profile of how our diet and our food is actually altered in the gastrointestinal tract. And this is one aspect that we are now going to address with the children, is beginning to understand those aspects. And we are also going to do something else, a spectroscopy of the teeth, which is what these children have been eating over the previous years. You can address this by spectroscopy. The issue of diets, the microbiome, and the issue of screening of the teeth are very complex, but certainly is a field for the future. But I would not like to pontificate.
Thank you, Dr. Fuster. Dr. Thomas has a question. Do women have a different trajectory of developing subclinical atherosclerosis before and after menopause?
Yes, they do. In fact, the data I presented at the beginning, 2/3 of men under the age of 50 had already subclinical disease when we're 50% of women. This all turns around with after age 50 in women, in which they accelerate the disease. And at the very end, by about age 60, 70, the amount of disease in women and men is exactly the same. So I think there's a difference in the biology. Now the question here is why. Very complicated. Are estrogens protective of women before menopause, or the opposite? Is testosterone affecting men before age 50? You follow? So, and there's a lot of data in one way or the other. So this is very complex, but certainly the trajectory is different.
Thank you, Dr. Fuster. We are nearly out of time, but if you could just say a few words, what is your advice to the new generation of early career cardiologists and cardiology fellows as they choose areas of investigation for their future careers?
First of all, they have to learn what their talent is. There are not many people who follow an investigational career, maybe 5% at the basic science level and 30% at the clinical level. But you have to know who you are and enjoy what you do. Number one, what you cannot do is to be guided by ambition on aspects that you not necessarily enjoy. We are just trying to achieve goals. You have to enjoy what you do. So the first thing I would tell them, somebody, mentors or tutors, have to tell you who you are. And once you know who you are, invest. And if you are a great person with curiosity and challenging and new things, you might be an investigator. Then you get there. But you don't get there just for the sake of it. You need an environment. But I think my main advice here is be sure who you are and invest there. The other advice is those of us who reach the stage that today we are here in the audience, and myself, we are very lucky. And therefore, better we give thanks and we play some role of creativity in society. And such creativity not necessarily is to write papers. You can be creative in an educational program and whatever it is. So the second comment is creativity. That's my second. And the third comment is team effort. We all evolved in the last few decades very much individually in the scientific world, I can tell you. Today, any world we are watched by everybody else, and better we team with everybody else rather than being watched. So I think the issue of team is critical. So this is my advice to a younger person. Know who you are, get mentors. Don't say you are so high you don't need mentors. Forget, I have 2 mentors at my age, because things get more difficult with age, by the way. So you need to have a mentor and who you are, play as a team. This is important, and enjoy what you are doing and be creative as an obligation.
That's wonderful advice, Dr. Fuster, very inspiring. And thank you so much for taking time out of your busy day to be with us today. It's really an honor to have you here. And we're so happy that you were able to give the same lecture after 20 years. Really a wonderful talk. Thank you so much.
I would love to give another lecture in 20 years from now.
We would love to have you back. Absolutely.
Thank you very much. It's a pleasure to all of you. Thank you very much to all
Thank you.
the listeners in the audience. Thank you.
Thank you.
Bye-bye.
Bye-bye. Thank you, everyone, for joining us tonight. Have a great night.